Good afternoon, everyone. We have a lot of people already online right now for this Zoom town hall. It's my pleasure to welcome you to this town hall session presented by the Southeastern Coastal Center for Agricultural Health and Safety. And thank you all for joining us today. My name is Ricky Telg. I'm the director for the UF-IFAS Center for Public Issues Education, or the PI Center as we're known as. The PI Center provides support for the Southeastern Coastal Center for Agricultural Health and Safety, which is hosting this town hall. Today's session will focus on COVID-19 with information specifically on vaccines. Before I introduce our two speakers, I want to share a few brief items. First, the Southeastern Coastal Center for Agricultural Health and Safety offers monthly webinars, and you can go to SCCAHS.org, as you see there on the screen, to find out about upcoming webinars, as well as to view our previously recorded webinars. Today's session is being recorded, and we will email a link for today's recording to everyone who is registered. When you did register for this event, you were given the opportunity to enter questions for our speakers to address. Many of your questions will be addressed during their presentations. At the end of the presentations today, there will also be a time for a Q&A or question and answer with our guests. We ask that you enter any question in the Q&A box in Zoom at the very bottom, and I will facilitate questions we receive and ask some of your also pre-submitted questions. You are welcome to submit questions throughout the entire session today in the Q&A box. However, we may not answer them until the end during the designated Q&A time. I'm pleased to introduce our two speakers for today's town hall. They will present in this order. Dr. Glenn Morris became the director of the University of Florida's Emerging Pathogens Institute, or EPI, in August 2007. He was recruited from the University of Maryland, Baltimore, where he was a professor and chairman of the Department of Epidemiology and Preventive Medicine in the university's School of Medicine, as well as the interim dean of the University of Maryland, Baltimore School of Public Health. In addition to his position as EPI director, Dr. Morris is a professor of infectious diseases in the UF College of Medicine, and Dr. Morris is the director of the Southeastern Coastal Center for Agricultural Health and Safety. Dr. Morris has worked in public health and pathogen-related fields for more than 30 years and has had a continuing fascination with emerging pathogens. At EPI, Dr. Morris has helped to shape the creative vision behind a web of campus-wide projects to anticipate, understand, and control the emergence of new disease-causing microorganisms. Dr. Morris started his public health career at the Centers for Disease Control, where he was an epidemic intelligence service officer and focused his attention upon cholera and other water and foodborne illnesses. He has served on 4 National Academy of Sciences expert committees dealing with food safety and was a member of the Food and Nutrition Board of the Institute of Medicine. In the mid-1990s, he worked with the Food Safety Inspection Service in the U.S. Department of Agriculture on the first major revision of food safety regulations since 1906. Dr. Morris also plays a key role in linking EPI with collaborative partners in Florida, the broader U.S., and international agencies. Under his leadership and with funding from the World Health Organization, the Gates Foundation, the National Institutes of Health, and the U.S. Department of Agriculture, EPI has developed collaborations with investigators in Africa, Asia, Europe, and South and Central America. Our second speaker will be Dr. Ira Longini. He is a professor in the UF College of Public Health and Health Professions and the College of Medicine's Department of Biostatistics. He is co-director of UF's Center for Statistics and Quantitative Infectious Diseases. Dr. Longini received his doctorate in biometry and biomathematics at the University of Minnesota in 1977. He began his career with the International Center for Medical Research and Training in Cali, Colombia, and following that, he was a professor of biostatistics at the University of Michigan, Emory University, the University of Washington, and now the University of Florida. He works on the mathematical modeling and biostatistics applied to epidemiological problems. He has specialized in the mathematical and statistical theory of epidemics, a process that involves constructing and analyzing mathematical models of disease transmission, disease progression, and the analysis of infectious disease data based on these models. Dr. Longini has worked on the analysis of epidemics of COVID-19, Ebola, influenza, HIV, MERS, cholera, dengue fever, Zika, and other infectious disease threats. He works with the World Health Organization on the statistical and mathematical models and methods for the control of international infectious disease threats. He is author of or co-author of over 220 scientific papers and 1 book. And now we'll begin with Dr. Morris and then following Dr. Longini. Dr. Morris?
It's a pleasure to be on. And again, my thanks for the introduction. After that, I'm not sure I can say anything at all. But what we'd like to do today is give you a little bit of background on COVID. Some of you have seen some of the webinars we've done in the past. Some of the material has been presented, but again, this is a field that's moving quickly enough that we wanted to sort of provide an update. And then Dr. Longini is going to talk specifically about some of the work that has been done on the vaccines and how, what we're learning about the vaccines may impact our ability to control this particular infection. Next slide. Next slide, or do I? There we go. So just as some background, these are coronaviruses, electron micrographs, actually growing in respiratory epithelial cells. And you can see they do indeed look like all the pictures with those little spikes there. And again, over on the right-hand side of the slide is a picture of the spike protein, which is a really intriguing structure, which actually has the ability to sort of hinge and move and connect with appropriate receptors. Next slide. So when we start talking about coronaviruses, I think the thing to emphasize is that coronaviruses are nothing new. Coronaviruses are common in domestic and wild animals, particularly for those of you in extension. You are probably very familiar with the diseases caused by coronaviruses in farm animals. There are actually 6 different coronaviruses that cause various types of infections in pigs, including porcine transmissible gastroenteritis virus. There's also bovine coronaviruses that can cause severe diarrhea in calves. Cats get coronavirus. Actually, cats can get COVID-19. But coronaviruses cause feline infectious peritonitis in cats, which is a very serious illness, which is actually not that uncommon in large cat colonies. Dogs get canine enteric coronavirus infection. So again, I think the point I want to make is that this is a widespread virus. And in fact, in humans, coronaviruses are one of the most common causes of upper respiratory infections. The common cold, this is human coronaviruses 229E, NL63, HKU1, OC43. Next slide. But actually go back, sorry about that. But the real problem comes with 3 specific coronaviruses that have managed to evolve specific virulence characteristics that can cause some significant problems in humans. And these are SARS, MERS, and COVID-19. Next slide. And again, just to sort of put these together on a phylogenetic scale, you can see the upper arrow, those are the MERS-CoV strains, closely related to the camels. And camels appear to be the major reservoir for MERS, which is Middle Eastern Respiratory Syndrome. SARS-CoV, down there with the slightly darker blue arrow. And the reservoir there appears to have been civets, moved from civets into humans, and you can see the 2 of those are closely related. And then in the red are what's called here the beta-CoV Wuhan, which basically are the SARS-CoV-2. And again, you can see here, there's a very close relationship to bat coronaviruses, with bats probably serving as the ultimate origin of this particular strain. Next slide. But this particular strain, COVID-19, and again, SARS-CoV-2 is the name of the virus, and it causes a disease called COVID-19, with the 19 simply standing for the fact that it appeared in 2019. This simply shows the spread across the past year. And as you can see, at this point, we're up in the range of about 95 million confirmed cases globally. The Americas remain the real hotbed for infection, particularly the United States. But also you can see there's a lot of activity in Europe, less so in Southeast Asia, Eastern Mediterranean, very little illness currently occurring in Africa. And interestingly, the Western Pacific, which includes China, little, if any, infection. They've gotten good control over their coronavirus epidemics. And they're not seeing the massive spread that we are seeing here in the United States. Next slide. What do we know about COVID? I think I would emphasize the fact that it's highly contagious. The transmission is by large droplets from the respiratory tract, which, as you can see in the figure up in the upper right of the slide, depending on the size of the droplets that carry the viruses can drop out in, in a foot, couple of feet, up to 3 feet, up to 6 feet, 12 feet. The danger zone actually for the large droplets probably goes up to 12 feet. But then what we are learning is that this virus also very commonly becomes airborne and can drift in air for several hours, creating what we term a toxic cloud. Now, we all talk about 6 feet being the magic number, but in reality, 6 feet is just sort of a mid-range that was sort of selected as being a reasonable point to try to stay separated. 6 feet doesn't protect you from, some of the droplets, and it clearly doesn't protect you from the aerosols. Again, here at UF, we've done a lot of work with aerosols. The bottom figure shows an experiment that we conducted over at Chance Hospital, where we were able to isolate SARS-CoV-2 from air in a hospital room using specialized machinery that we've got that pulls air through a special machine that allows for culturing. And we were able to show the patient number 1 in bed number 1, we were able to isolate his virus over in the machine over by the bathroom, which was about 20 feet away. And so again, we are learning that airborne transmission like this is actually relatively common and probably accounts for much of what we call the super spreader events, where large numbers of people within a single room can become infected. I would emphasize that the virus can be transmitted by persons who have no symptoms. This can occur before or after clinical symptoms or in persons who never have clinical symptoms. But back at the beginning, everybody was really fixated on, disinfecting bags from the supermarket. We are not seeing that much evidence that there is transmission on surfaces. This is really a virus that you pick up from the air due to being in the vicinity of somebody who's infected, either because of spread of large droplets, which means you're fairly close to the person, or through spread of aerosols and aerosol droplets, well, not really droplets, spread of aerosols containing the virus, where, again, one single infected person can infect an entire room of people. Next slide. Clinical presentations, the typical case, one sees fever, cough, upper respiratory symptoms, sometimes diarrhea. The classic symptom is loss of a sense of taste and smell. If somebody tells you they've lost their sense of taste and smell, I can almost guarantee you that they're infected with SARS-CoV-2. Onset of symptoms is usually around 5 days after exposure. I would note that somebody becomes infectious probably 2 to 3 days before symptoms appear. And that may actually be the period where there's the greatest risk of transmission, are in those day or 2 or 3 before onset of symptoms, when people are walking around feeling fine, but very actively spreading the virus. I would note that this is not just the little flu. There can be clearly severe cases, worsening of symptoms over subsequent days with hospitalization, usually occurring around 11 days after exposure. Usually the key symptom there is increasing shortness of breath. Hospitalization, because it comes, when you're well into the course of illness, means that hospitalization data tends to follow after the data on case rates. One sees respiratory failure with fibrosis of the lungs, but there's also involvement of the brain, heart, kidneys, liver, GI tract, lining of the arteries. The little photomicrograph is from a study that one of our UF investigators took part in, and the virus is actually in the lining of blood vessels in the brain. Needless to say, the fact that we got a sample of blood vessels in the brain implies that the patient did not do well. Issues with a hypercoagulable state, which can lead to strokes and heart attacks. Kids, we are seeing increasing issues related to what we call multisystem inflammatory syndrome, or MIS, which resembles to a degree Kawasaki syndrome. However, I'd note that up to 50% of infected persons in large population-based studies are asymptomatic, with another 30 to 40% having only mild symptoms. Next slide. One of the things we are coming to appreciate much more commonly is the persistence of symptoms after infection, the so-called long haulers. This isn't just people's imagination. It's becoming very apparent that this is real. This is data from a study that was done in France, looking at people about 3 to 4 months after hospital discharge. And you see that over half still were complaining of fatigue, plus shortness of breath, memory loss, sort of what people call brain fog. And we're seeing evidence of short-term and possible long-term organ damage, as well as anxiety, depression, issues with self-care, reduction in activity. These long-term complications are becoming more apparent and are clearly of concern. Next slide. How do you detect it? You can detect it by looking for the presence of the virus. That tells you who's actively infected and has the potential for spreading the virus. You can do this by using a nasal swab or saliva and do what's called an RT-PCR test. This is what we call the gold standard test. This is the most accurate. We are starting to see more and more usage of antigen tests, rapid antigen tests that look for virus antigens. These are approved, but the sensitivity is reduced as compared with RT-PCR. And in fact, in asymptomatic patients, there's some data that suggests that these tests may only pick up 1/3 of infected people. So actually, they're not recommended for use in asymptomatic individuals. The other thing that's out there are antibody tests. I would emphasize that antibodies do not indicate whether or not you're infectious. They just show whether or not you've developed antibodies to the virus, which may have occurred with a prior infection weeks or months ago. That's a blood sample. By the time antibodies show up, people are likely not be infectious. Florida does keep track of positive antibody tests. 11% of commercial lab tests for antibodies are positive. But again, the people who tend to order those tests or ask for those tests tend to be people who think they've had COVID. So it doesn't really tell us that much about how common COVID is in the general population. Next slide. Who gets COVID? These are data from Florida cases. As of yesterday, you can see that 32% of deaths are in people aged 85 and above. And actually, if you look at those 65 and above, they account for 83% of all deaths. This again is one of the reasons there's been such a strong emphasis on vaccinating those 65 and above, because that's where deaths occur. Now, deaths do occur in younger individuals, and clearly there are risks of hospitalization and the long-term complications that we've noted in younger individuals. Next slide. So what are the risk factors for more severe illness? Age, actually this was more, I didn't change the slide at former talk. Age 65 or older. Also increased risk with cancer, chronic kidney disease, COPD, immunocompromised state, obesity, a body mass index of 30 or higher, which is not that much overweight. Even a moderate degree of overweight can significantly increase your risk. Serious heart conditions, sickle cell. Some evidence, note that pregnancy, there are data suggesting that pregnant women who become infected were more likely to be hospitalized, require ICU admission, and require mechanical ventilation. Next slide. So how do you stop transmission? things that work are physical distancing. As I said, 6 feet is what's normally cited. But again, the basic rule of thumb is every meter that you're further apart, you reduce your risk by half. Doesn't go away entirely, but you reduce the risk. Masks, what are called N95 masks, are highly effective in blocking passage of the virus and preventing infection. Medical grade masks, maybe as much as 85% reduction in infection. Cloth masks, they still have some effect, although they are less effective. CDC guidelines indicate that there should be multiple layers of cloth, reasonable fit, cover nose and mouth. If you could advance the slides. Definitely one should not use what are called gaiters, or those sleeves that slide up over your face. We've tested them here, and they've been tested by other groups, and they really don't provide any protection at all. Same with bandanas. They also don't work. Don't use those. In fact, CDC is now starting to move forward to certifying certain masks as being better than others. They really need to do that, because there needs to be an awareness that it's not just slapping a piece of cloth over your face. It really does need to be something that's engineered properly to minimize the risk of transmission. Face shields, there's some data that says there could be as much as a 65% reduction in infection, but those data are pretty soft. Hand washing is clearly very important. And stay outdoors as much as possible to minimize the risk of formation of aerosols. Next slide. The other thing that works is actually identifying people and then monitoring them, calling them, getting them to quarantine, to isolate if they're infected, to prevent spread and transmission to others. And again, the graphs over on the right side of the slide simply show models that have been done showing that if you don't do testing and tracing, you get that major spike, but you can have significantly reduce the transmission if you really can work aggressively to identify infected people. And once you've done that, to try to make sure that they are isolated and that people that contact infected people are appropriately quarantined. It really does work. And again, these are simply some trucks put out, that go out by, under the auspices of the Florida Department of Health to do testing in a variety of locations, accessible testing sites, pop-up testing. You need rapid turnaround time, quick answers to be able to actively utilize the test and trace mechanisms. Next slide. Therapy and vaccines. Therapy, there's no magic bullet. There's remdesivir, it shortens hospitalization, but it really doesn't influence mortality. The monoclonal or polyclonal antibodies you may have heard about, what President Trump got at the beginning of his infection, are helpful in the early stages of infection, but once you're hospitalized, once you reach a certain point, they do not appear to be of that much efficacy. Steroids are of clear value for moderate to severe illness. Anticoagulation can reduce clot formation. And again, I'm going to let Dr. Longini talk more about the vaccines, but simply to note that there are, at least according to the webpage yesterday, 64 vaccines in clinical evaluation globally, 173 in preclinical development, and then there were the 6 vaccines that were developed here in the United States. Next slide. The other thing that's really starting to attract attention are what we call SARS-CoV-2 variants. And variants are, again, something that happen all the time with viruses. Viruses evolve regularly over time, and certain evolutionary changes make the virus more effective in terms of its ability to transmit or possibly increase its ability to cause disease. So the appearance of SARS-CoV variants in the midst of a global pandemic is expected. The problem is we're starting to hone in on certain variants that appear to be causing or have the potential for causing some problems. One is the one that's called B117 that was identified in England. There's P1 from Brazil. There's 501YV2 from South Africa. There is a suggestion that some of these, particularly the B117, can cause increased transmissibility, maybe increased virulence, although that remains controversial, immune avoidance, decreased vaccine efficacy. Again, that remains controversial. The little map here shows the frequency of some of these variants. This is work that's being done by a private company called Helix that has been under contract to CDC. And what you will see is that in actuality, here in Florida, they have identified a fair number of these variant strains. On this map, 49 B117s. But the problem is still the amount of sequencing done is minuscule compared to the number of strains. And unfortunately, here in the United States, we always seem to be behind the curve. We were behind the curve in testing. We've been behind the curve in a lot of stuff. And where it is becoming increasingly critical to be able to do sequencing to find out which variants are circulating, we're again behind the curve and really have very limited sequence capacity. And in fact, and somewhat frustrating, the state says that because of various regulatory concerns, even though we've offered to sequence strains for them, that we can't do it. So right at the moment, we don't know what's going on. It's of concern, but we're not sure how much concern. Next slide. So to summarize, COVID-19, highly contagious, transmission by infected persons who are asymptomatic, transmission by respiratory droplets and aerosols. Among infected persons, half are asymptomatic or only mildly symptomatic. Mortality rates in the 0.5 to 3% range. Those at high risk, over age 65, diabetics, those with obesity, cardiac disease, frail, elderly. Interruption of transmission, physical distancing, avoidance of closed spaces with large numbers of people talking loudly or singing. Stay away from those bars. And masks. To quote our illustrious senior senator, everyone should just wear a damn mask. And I think at that point, I'm going to turn it over to Ira and let him talk about the vaccines, which right at the moment are really kind of at the forefront of where we are. I've tried to give you some background on the infection, but then the real question is, what approaches are we using right now to try to get this pandemic under control?
I know that Philip is switching the PowerPoint slides over, so I didn't know, Ira, if you had something to mention in transition until the other slides come up.
Yeah, so I don't agree with anything Marco Rubio says except that last statement. So as you know, with vaccines are here, and we're vaccinating in Florida, and the vaccines are not going to save us, but they're not a magic bullet, but they can help considerably, and they're a very important part of our armamentarium for dealing with COVID-19. So what I'd like to do is go through some of the characteristics of, at least of the vaccines being deployed now in Florida, and then talk about the potential impact of those vaccines based on what is happening. So I'll try to reflect both, as you know, vaccines protect individuals that are vaccinated, and then others that they would infect if the vaccinated people gotten infected. Hopefully vaccines reduce that transmission. So both the individual perspective and then the group societal perspective. Next slide, please. So there's 4 basic classes of vaccines under development. As Glenn mentioned, there's over 200, probably more under development. There's live attenuated virus vaccines. Can you see my cursor? I'm moving it now.
Yes, we can see the cursor.
The white one. Good. You see the white one?
There's a black one on there.
Oh, no, the black one is not the right one. Okay, thank you. So ignore the black one. I'm not doing that actually. Those are the ones you're very familiar with, such as either live attenuated or inactivated, think flu vaccines, which we have both types. There's the nucleic acid vaccines, which can be either DNA or RNA based. And we're in Florida, we have 2 RNA COVID vaccines that are currently being rolled out. There's viral vector vaccines, that use another virus as a vector. There's one of those vaccines coming along, several of those for COVID, and then protein-based vaccines, either virus-like particles or protein units. Next slide, please. This is my last update, which is changing daily on the basically 95 vaccines that are in some phase of clinical development, 1 through 3, or have been abandoned. And there's among those, there's the Pfizer vaccine and the Moderna vaccine, both RNA vaccines, both that have been given emergency use authorization, and both of which there are published results about how efficacious they are. They're phase 3 results, either based on interim or final analyses. And then you'll also hear about, for example, the Gamaleya vaccine, which is a vectored vaccine made in Russia. And even though that vaccine has received basically licensure in Russia and is being rolled out in a number of places, there are no published phase 3 results. In fact, no phase 3 results reported except anecdotally for that vaccine. There's the AstraZeneca vaccine, which is a chimp adenovirus vectored vaccine that also has published results, gone through phase 3, and has received emergency use authorization in Britain, India, and other countries. And then there's a whole host of other ones shown there, many of which we know very little about, even though they're in phase 3. We don't know what their protocols are, or we have virtually nothing published or even reported on the results. The Johnson & Johnson or the Jensen vaccine, which is an adenovirus 26 vector vaccine, we should get phase 3 results and very quick published results on that vaccine within weeks, possibly followed by the Novavax vaccine, which is a protein-based vaccine. The other ones listed here, we don't know much about. And we have to have, of course, published phase 3 results and careful regulatory scrutiny and authorization to be actually used. Next slide, please. Before I show you results from these vaccines, I just want to talk about how vaccines work, because there's a lot of confusion about this. Being a statistician, I'll do this in symbols. Vaccines can protect against infection, and so we call this efficacy against infection, VES, meaning reduction in susceptibility. They can protect against disease or clinical progression given infection, we'll call that BEP, or they can protect against clinical disease among those who are infected. So the two together. So that would be, the primary endpoint in all the phase 3 trials we've looked at so far. In other words, the outcome of those trials was the primary outcome was a number of people with clinical disease that's confirmed. So a number of people with clinical disease confirmed by PCR. And so that's what we know something about. How well do these vaccines protect against clinical disease, any clinical disease in those who get infected? And that VESP, if you live in a multiplicative world, is a function of the VES and the VEP. And then finally, there's the VEI, vaccine efficacy against transmission to others, given somebody's infected. So how much does vaccine reduce directly transmission, viral shedding, and so on from infected vaccinees? And we know at this time virtually nothing about that efficacy. So keep in mind, the only one we know is the VESP. Next slide, please. So here is the VESP for the Pfizer vaccine trial. What you're looking at is the cumulative incidence, and the blue, if you look at the bigger plot, is the cumulative incidence in unvaccinated people on placebo, and the red is the cumulative incidence in individuals who are vaccinated, counting from day 0, so when the first dose occurs. And in this particular vaccine, the second dose occurred around day 21. So you'll see a steady march of cases among those who got the placebo, and an equal increase among those who were vaccinated up to about day 10 or so after the first dose in the vaccinated. And then that curve goes relatively flat with just a few cases after that. So that's how the vaccine's operating. The primary outcome for the trial was counting 7 days or more after the second dose. And if you base your efficacy measure on that, you're looking at 9 placebo recipients versus, 172 placebo recipients versus 9 vaccinated recipients. So that's an efficacy of about 95%. But you can also look at other efficacies. For example, before the first dose, after the first dose, but before the second dose, it's about 50% protection, and so on. So the bottom line here is that you get about 95% efficacy eventually from these vaccines against clinical disease from this vaccine. And that protection starts roughly starting around 10 days after one is vaccinated by the first dose. Next slide, please. This is a further breakdown on the efficacy of the Pfizer vaccine. As I said, overall about 95%. And remember, that's the primary outcome of the trial, so that's the one result we can really count on. But there's all these sub-analyses shown here, which gives some indication of how the vaccine protects against various age groups, depending on, obviously, smaller numbers, and also post hoc stratification analysis with all the biases that may come with that. But it looks like quite good efficacy as a function of age, gender, ethnic group, and race and ethnic group, and in the country where the trial was carried out. So roughly 95% or so protection against clinical disease. We don't know what the protection is against infection. So next slide, please. This is the other vaccine, the Moderna vaccine, similar cumulative incidence curves. You can see the curves pulling apart after about, in this case, about day 14 or so, but a very similar pattern to the other vaccine. And here, the efficacy is about 95%, 93% in this particular case. So that's the Moderna vaccine. Next slide. Breakdown on the Moderna vaccine shows, again, good efficacy as a function of all these subgroup analyses. Again, keeping those analyses, these are not the primary outcome. The only primary outcome is the top one. But it does appear to protect pretty well for older adults and across these other covariants. I should mention that on both vaccines, the safety, they both have a good safety profile with minor side effects resolving in 1 to 1.5 days after people are vaccinated. So there's no real safety concerns with either of these. Next slide, please. So this is just a summary, and I also put the AstraZeneca vaccine in because we do have published results on that. But so you can see, we know the VESP for the 2 RNA vaccines. It's a bit lower and nuanced for AstraZeneca, in the 90s for the RNA vaccines, and perhaps in the 70s, the 80s for the AstraZeneca. We do know, it looks like, and I didn't show you the results, but there are very few severe cases in the vaccine vaccine arms for all these vaccines compared to the placebo arms. So it looks like high efficacy against severe disease, but the numbers are very small. What about VES protection against infection? We don't know much, but kind of teasing out what little we do know from the Moderna and the AstraZeneca trial, how well do these vaccines actually protect against infection? It's probably no better than 60%, and we know nothing about the VEI. Next slide, please. So other things we don't know. First of all, one thing we do know, none of these vaccines are licensed. They're approved for emergency use authorization only. We don't know enough about the safety and efficacy of these vaccines to license them at this time. We don't know how durable protection is beyond 120 days. We don't know how well these vaccines, as Glenn already indicated, work against these new variants. We don't know how safe they are for rare severe outcomes. That's outcomes with frequencies of less than 1 per 100,000 or maybe even 1 million vaccinees. We don't know if we'll get enhanced disease for breakthrough cases of vaccinated people, which is a possibility with COVID virus. We don't know what the VE is for infection against transmission, severe disease, or death. And we don't know, we know a little bit about certain risk groups, as Glenn indicated, but not very much. How well do these vaccines work in elderly, the immunocompromised, et cetera. Of course, we know nothing about how well they work in children because they were not tested in children. We don't have an immune correlate of protection. So if you get, at this point, vaccinated and you can measure your antibody level, we don't know what antibody level is really protective. Next slide, please. So that's what we know about the vaccines. I would mention, I just got my second dose of the Pfizer vaccine yesterday. I have a sore arm, but no other problems. And maybe some of you have been vaccinated already. So that's what we know on an individual level. So now I want to go to the, what does this mean for Florida and the impact of vaccination near term? And for that, we have to go to modeling. We've done some modeling, mathematical modeling. Next slide, please. So we've used it's an agent-based model that lets individuals pass through susceptible to incubating to infected at different rates. And it keeps track of all these things, the asymptomatic, mild, severe, critical, and fatal. It has probabilistic state durations and a lot of nice modeling characteristics. Next slide, please. It's set up to model all 20.6 million of us individually in the state of Florida in all our respective households, schools, long-term care facilities, hospitals, workplaces, and so on. Next slide, please. So what do we assume? Since we're modeling, we have to assume something about the efficacy of these vaccines. And so we assume the vaccine efficacy against susceptibility is 60%. That means if you're vaccinated, it reduces your probability of infection per contact with an infected individual by 60% compared to an unvaccinated person. That if you do get infected, it reduces your chances of having an illness by 88%. And this is based on a VESP of 95%. And then we assume that efficacy starts occurring after 10 days, consistent with the data that we have on these vaccines. Next slide, please. We looked at 2 vaccination campaigns, possible campaigns under different conditions in the state of Florida. We assume vaccination started beginning in January of 2021 that will eventually reach 50% coverage and that will vaccinate 65-year-olds first and then follow that by vaccinating 16 to 64-year-olds once they're covered. We assume 2 rates of distribution. One rate, which is about 0.12% of the population per day, are 25,000 people vaccinated per day with the first dose. And that's what we're currently doing. And we also looked at what if we ramp up, and I hope we're doing that according to the Biden plan, to vaccinate 0.3% of the population of Florida per day, or about 62,000 people per day with the first dose. Next slide, please. So what this is showing up top is the effective reproductive number, the black being nobody vaccinated, the blue being the slower rollout, and the green being the faster rollout. And as long as that number is above 1, the epidemic is rising. If it's below 1, it's coming down. And you can see, even with doing nothing, we're going to get a decreasing reproductive number, and it just comes down faster with either the slow rollout or the faster rollout comes down faster. And that below that curve just shows the cases per 10,000 in the state per week, adjusted for all the reporting problems we've had in Florida and delays. So that's what the curve really looks like in Florida, according to the model. And you can see, starting in mid-February, some reduction in the number of cases, and the same thing for deaths per 10,000. So the vaccine will have a relatively small impact on the curve compared to if we did not vaccinate with this rollout strategy. If we get the current or the past strain of the virus spreading. Next slide just describes how we adjusted the observed curve in Florida, which you see below, to what really is going on underneath, which is shown above. So I won't go into that. Next slide, please. So the other way to look at the impact of these vaccines, or how overall effectiveness, how much do you reduce, it's called the overall effectiveness, the number of cases in the entire state when you vaccinate compared to when you do not vaccinate, and then number of cases averted or deaths, which are the number of cases we would have had or deaths if you had not vaccinated minus the number you get when you do vaccinate, so cases averted. So that's a better way to possibly look at the impact. So next slide, please. The upper slide's just showing what I showed before, but I'll get, if you go down to the right-hand side, the right-hand plots, the cumulative sorry. Yeah, go to the 10,000 cumulative cases averted per 10,000. If you look at the bottom plot on the left, you can see you avert quite a few, up to by over 100 cases per 10,000 to slow with the fast rollout, and about 50 in the slow rollout. And if you look to the right of that, you can see that eventually we'll have prevented about 2 deaths per 10,000 people in Florida with the slow roll, fast rollout, and a little over 1 with the slow rollout. Next slide, please. However, we could have, if, as Glenn showed, the more transmissible mutant strain from the UK and others transmit in Florida, assuming those are 50% more infectious. This is showing the epidemic we would see in Florida if that happens. The black, if you look at the second plot down on the left, shows we would get a much higher peak in April or so. And you can see what it will be with vaccinating at either the slower rollout or the fast rollout on the left for cases and on the right for deaths. And now, if you look at the bottom plots, we'll be preventing quite a few with the fast rollout, close to 200 cases per 10,000 people with the faster rollout, and 4 deaths per 10,000 people with the faster rollout. So it makes a much bigger difference if we end up with this much larger epidemic due to these more transmissible strains. Next slide, please. So what we conclude from this is the main benefit will be prevention of death and severe disease among those who are vaccinated of the vaccination campaign. The vaccination campaign is too little too late to really disrupt the 2021 transmission, but variants could make the spring much worse, the spring of this year, and then we gain quite a bit more benefit from vaccination. And what we'll look into, though, is as we continue to vaccinate and get coverage levels up higher and higher in the state, will we be able to prevent future waves of the epidemic, say in 2023? Because the virus is probably not going to go away. So we may find that we'll still need to get vaccination coverages up quite high to prevent future transmission of the potentially variants of this virus, if not the current virus itself. Next slide, please. So that's it. Thank you very much.
Great. Thank you so much, Dr. Longini. Appreciate it. Dr. Morris. We do have some time for question and answer. This town hall goes through around 2:30. We have a few already typed in. I would encourage those of you who are attending to, if you have questions, to put those in your Q&A, and we'll try to answer as many of those as possible. I also have some of the questions that were provided earlier as well. So one question that was asked early on, and I think this was during Dr. Morris's presentation, is do antibodies wear off after a time?
I'm not quite sure what you mean by after a time. Yes, antibodies drop off over time, definitely. And you know, certain antibodies tend to last a lifetime. Once you had a case of measles as a kid, you were protected your whole life. But in contrast, coronavirus antibodies tend not to last that long. They are a common cause of the common cold. And as you know, you continue to get colds every year. And so consequently, the antibodies that are raised by a cold one year due to coronavirus are not necessarily going to protect you the next year. We don't really know how long the antibodies generated by a case or the antibodies generated by vaccine are going to last. We're too early in the game. We are hopeful that we will see protection for at least a year, potentially 2 years, but I think most people are in agreement that given what we know about other coronavirus strains that we see in people, that we're probably not going to be getting lifetime protection. So the bottom line is you're probably going to need to get another shot again at some point. And part of it's also going to be dictated by the variants. I mean, keep in mind, we get a flu shot every year because the flu virus undergoes changes. And so a new virus is, a new vaccine is put together directed towards slightly different viruses. We may find ourselves in that same situation with coronavirus, where every year there have been enough changes and the accumulation of enough variants that it becomes necessary to generate a new vaccine that is slightly different and provides protection for that particular year.
Okay, thank you for that. And Ira and Glenn, I'm going to try to go through the order that we're receiving most of these questions in. So if you can see that on your Q&A there, I'm not sure if you can or not, but I'll go ahead and read the question for our attendees. And this one is about child vaccine. It says, do you have an update on child vaccine and when that might be available? I have a high-risk child. If most adults, including teachers, but not children, are vaccinated, is it reasonable that the risk to my child is much, much lower to attend brick and mortar school come fall of 2021?
I can take a crack at that. So there's certainly, so we know the phase 1 through 3 trials, at least for some of the vaccines, were conducted in 16 years of age and up. And there are currently, for several of the vaccines, at least safety and immunogenicity trials, phase 1 and 2. being conducted in children possibly down to the age of 9, maybe a little younger. And so we'll have safety and immunogenicity data in children, I think fairly soon, within a few months. Whether or not the children are protected or not, we probably won't get phase 3 data for that. And that's where we might have to depend on immune correlates or surrogates if we can get them. But I really wouldn't know. You couldn't hazard a guess whether I'll be able to start vaccinating children by the fall with some of these products, but I imagine we probably will. Yeah.
Great. Thank you very much. I'm going to group a couple of questions related to masks together. So one is, should masks be worn after receiving the second dose of a vaccine? And related to that is, are there any thoughts on how we can encourage folks to properly wear their masks? So two unrelated but somewhat related type questions related to masks.
I think part of this gets back to the point that Ira was making earlier, which is that what the vaccine efficacy trials tested was the occurrence of clinical disease. And the actual efficacy for infection may be lower than the 95%. What that means is that you still may get infected with the virus and can transmit the virus, but the viral load is low enough that you don't get clinical symptoms. And so consequently, the recommendation right now is that you need to keep wearing a mask because there is a possibility that you could have picked up the infection and could potentially transmit it to someone else, even though you may not be getting symptoms. Now, there will come a time when we're no longer recommending that, in part when the pandemic gets under control. The problem we've got right now is we are still in the midst of a major pandemic with high levels of transmission, some of the highest transmission levels in the world occurring here in the United States. And if we're going to get the overall pandemic under control, we need to slow down the transmission rates. And under those circumstances, continuing to wear a mask, even though you may be protected against disease or severe disease, you still may actually have picked up the virus and have the potential for spreading it on to somebody else. So how do you get people to wear masks? I don't have a good answer. Unfortunately, mask wearing has become extremely politicized, which is crazy. I mean, this is a simple public health intervention. Simple, easy, inexpensive, and it works. But there are a substantial proportion of the population who, for political reasons, feel that they should not wear masks. And this has been a problem, and this is one of the reasons why the US continues to have one of the highest transmission rates in the world.
Great, thank you very much for that. One question came up about the models that were used. This is, why do the models expect spikes in the summer?
It's simple to answer, because we have spikes in the summer. There's no indication that coronavirus has a seasonal component the way influenza virus and other respiratory illnesses do. The model doesn't have any mechanism to reduce transmission during the summer months, other than the model does have does track behavior and the amount of people that are inside and outside and levels of interaction are in the model. And so that that would tend to suppress things a bit in the summer when people are outside more and so on. But we certainly have no observation that in fact, Florida had a big spike in the summer, as well as every other state, as well as all over the planet, both in the northern and the southern hemispheres.
Great. I'm going to pick up a question that relates to something that Dr. Morris, you said before about the mindset about vaccines, about being able to spread it. So the question is this: there seems to be a mindset or misunderstanding that if you've had the virus or the vaccine, you can no longer spread the illness and therefore do not need a mask. can you share appropriate statements to share with those individuals? And you kind of hit upon that earlier, but I think what this person's asking for is, what would be an appropriate statement to share with those individuals who don't think that they need to, even though they've had the virus or had the vaccine?
Well, again, what we're seeing is that some people continue to be positive for the virus after they've had an active infection. In general, it looks like the risk of transmission is minimal after 10 days from onset of the infection. But I think what we come back to is this idea that we are still in the midst of a major pandemic. For people with a vaccine, we know that there is a possibility that they could be infected, i.e., carry the virus in their mouth and throat and be able to spread it, even though they've had the vaccine. The vaccine will significantly reduce the chance that they're going to get symptoms or severe disease, but there remains at least a small possibility that they will be able to transmit the virus. So under those circumstances, in the midst of a major epidemic, it makes sense to wear a mask. The other side of it is that, and this gets more into psychology, that what we're trying to do, what public health authorities, what Biden has said is, let's do everybody wear a mask for 100 days. Let's really try to get a high level of mask wearing. And if you're not wearing a mask, what it does is reduce the overall sense out in public that people are wearing masks. And so until we hit a point where there's very little transmission, it's not a bad idea to wear a mask to minimize the risk that even if you have been vaccinated, you might still transmit, or to sort of show people that you are, in favor of masking.
Thank you very much. One question, I'm not sure if it's been answered in this way before, but I would like to go ahead and restate it. Question was, I need some help explaining vaccine effectiveness to the general public. Would it be accurate to say that the following: if 100 people are vaccinated, about 95 of them will be protected from getting sick?
Yeah, so that's vaccine efficacy. And that's not accurate, though. What the definition is that if I vaccinate 100 people and then I compare them to 100 unvaccinated people, that the probability that the reduction in the proportion that gets sick is in the vaccinated people compared to the unvaccinated is 95%.
Okay. I hope that answered the question who submitted this. One question that has come up is, do you have any information regarding severe side effects? I know that was one of the points in one of the slides. Has there been any reported about in terms of severe side effects? I would assume that's related to the vaccine.
Yeah. Well, I think our only accurate assessment of so far of side effects is in the vaccine trials themselves, because if somebody has a side effect, you don't know if it's due to the vaccine or that it would have happened anyway, except when you're comparing people who got vaccine to people who got placebo at the same time. So based on that, it doesn't appear there are, the rate's quite low, and there were no, for the most part, no serious side effects, in the trials. Now out in the field, we're getting reports while we're just rolling the vaccine out that some vaccinated people have died. Some have had severe anaphylactic reactions, all kinds of things. Quite a few of which may have had nothing to do with the vaccine. There is a report of very frail people being vaccinated in Norway in rest homes, some of them dying. And the question is, would they have died anyway? They were very frail, and had they not received vaccine. So yes, there are reports of side effects and some are severe, but they're hard to interpret except from the vaccine trials themselves, which so far have not shown any serious problem with side effects. That doesn't mean we shouldn't monitor and investigate all the side effects that happen out in the world as the vaccines rolled out. But you have to be very careful in making sense of those reported side effects.
I'll let you just chime in. I am in complete agreement with what Ira said. However, people do need to be aware that, you know, a fairly substantial percentage of people who get the vaccines do experience some mild to moderate side effects, most of which disappear fairly quickly with a Advil or a Tylenol. And particularly with the second dose, there can be more severe side effects, still in the mild to moderate range. Interestingly, young people seem to have more problems sometimes with side effects than older folks. But we are seeing it in our hospital personnel. And so, you know, it's not a bad idea to get the vaccine, particularly the second dose, on a day when you're going to be able to take the next day off, just in case you don't feel good. So again, be aware that sometimes you may not feel that good the day after. But as Ira said, serious complications we are not seeing. We are seeing occasional cases of anaphylaxis, but those have all been very rapidly treated and have been handled without problems.
Yeah, and emphasize that I'm in my day after right now, the second dose. I feel pretty good, but not great, and I have a sore arm. So, and my arm is sorer than it was the first time.
Great. This next question is a little bit long. It's a little story, and I want to read this to everyone because it relates to communicating messages. And it's this. It says, is UF Health communicating with municipal leaders? My city requires masks in city buildings, but then the city purchased these neck gaiters for all of their employees. It would be nice to help them learn about the recommendation to not use bandanas and neck gaiters, and then provide them with the correct messaging and communication to help explaining how science evolves with research, and now that these are not good enough. The suggestions were maybe working with the League of Cities or the Florida Association of Counties. But I think this overall question is about, you know, cities and counties are doing things like buying these neck gaiters. What would be an appropriate message or something to communicate to them? Because many of our extension faculty out in the state may be dealing with exactly this type of thing.
This is tough. And again, I phrase this delicately, there has not been substantial reliance on you know, scientific expertise in many instances. Unfortunately, a lot of the decision-making has been pushed down to the county level, where there may not be local experts who really keep up with the literature and the recommendations put out by CDC. Actually, the CDC webpage is very clear. It says specifically, don't use bandanas or neck gaiters. So if somebody in the county had read the CDC guidelines, they would know that those were not appropriate. But the problem is there's probably not anybody in the county who's going to be reading the CDC guidelines on a regular basis. And so this is where really at a state level, the information needs to be being communicated down. And so far, unfortunately, that has not occurred. And as a result, we tend to get these types of problems arise. I think the thing to do is, and again, particularly for those of you who are in extension, you know, tell people to look at the CDC guidelines or go through and read the CDC guidelines yourself and be aware that these are problem areas that need to be pointed out. I think some people have sort of taken the attitude of, you know, if I can get somebody to wear anything, you know, I'll be happy in terms of face coverings. But again, the reality is I'm not sure I agree with that. I think if you're going to go through all the effort to get somebody to wear a face covering, at least wear something that works. And again, CDC hopefully is going to start moving towards some type of certification system so that there's some sort of little stamp or approval or something that says this face mask is approved by CDC.
Great. Thank you for that. One question I think for Ira, it says with the different types of vaccines, the ones that you mentioned before about live virus, the mRNA and others, do you anticipate pushback of individuals asking for certain types of vaccines? For instance, a primary care physician has the Johnson & Johnson vaccine, but the patient wants the Pfizer vaccine. So how would that potentially work, I guess?
Well, so far, if there were substantial differences in efficacy of these vaccines against various things, and they're published and clear, yeah, I could see where this might start to happen. Why would you want a vaccine that has 60% efficacy if you can get one that has 94% efficacy? But we're nowhere near that situation yet. And I think at this point, people would just have to be happy with whatever vaccine's available to them, even if they wanted a different one. But sure, eventually, when there's different vaccines with different efficacies against different things, then people will probably want, request that they get certain vaccines. I mean, it's somewhat a situation with some of the flu vaccines now. There's several available, and recommended, for high titer vaccines or, nasal spray versus injectable. And I don't think it's become as a big problem. I think people are generally are happy with whatever vaccine they can get as long as it's safe and efficacious. So. But I can see eventually where if there were many vaccines available, this question could get more nuanced. Yeah.
Great. Okay. There's a question here about masks. It says there's a good bit of talk in the media right now about double masking. What are your thoughts on double masking, especially if an N95 mask is not available to everyone?
Great idea.
There you go.
No, I mean, again, we've actually done experiments with masks here in our laboratories. And, there are striking differences in terms of the ability of certain masks to permit passage of virus particles. And again, gaiters are worthless, but, some of the other stuff that's out there for sale isn't all that great either. And by double masking, you can sometimes significantly improve the degree of safety. As I said, a good, hospital grade, medical grade mask really does provide substantial protection, not as much as an N95, but it's pretty good. But if you can't find any of those, then the double masking is a reasonable approach.
Great, thank you. We still have several questions in the Q&A, but I want to go to one of the questions that was submitted early on, because I don't want to lose this one. And this has to do with agricultural and health organizations or ag industry. And that is, what messaging should ag safety and health organizations use regarding the vaccine? And I'm going to put in there, especially regarding related to their workers, the agricultural workers. So what messaging or importance should be provided to agricultural organizations and ag safety and health organizations regarding the vaccine?
I feel extremely strongly that it's critical that the agricultural workers be included within the vaccination campaigns. And again, I was noticing one question that showed up in the Q&A saying, well, if you still might transmit, even if you get vaccinated, why do it? Well, the risk of transmission is much, much, much reduced. And, it also protects you. So yes, vaccination does work. And there will come a time when we have things under control. But if we have, particularly some of the agricultural workers, the migrant workers, H2A workers move around a lot, have the potential for spreading strains easily, are under conditions where there is easy transmission. And it is clearly, from an overall societal public health standpoint, it is critical that we try to minimize transmission. And again, this is a high-risk group where transmission occurs very frequently. And it's critical that we get the vaccine to these individuals.
Yeah. Yeah. I'd like to mention, again, I'm putting on my WHO hat, and what we're working on is we really feel that we need much more targeted and nuanced rollout of this vaccine and these vaccines that we currently have. And we're not, that's going to have to change. We just can't, blithely vaccinate by age group. I mean, we'll have to start at some point targeting, groups that are highest risk both to themselves and transmitting to others, whether it's agricultural workers or maybe even contact tracing type applications. And that's going to come. We can't just slowly roll out the vaccine. As you've seen, that's not going to help us that much. It'll help us individually, but not get the virus under control. So the kind of thing Glenn's talking about, we're going to have to start thinking about targeting specific populations and vaccinating them while we roll out the vaccine as well. So,
thank you.
And that's coming. We can't do what we're doing.
Great. And again, just to reinforce this, the idea, particularly for many of the agricultural workers, they're not going to come searching for the vaccine. And what we are doing right now tends to, go toward folks who know how to use the internet to make appointments online, to get in, find the vaccine, find where it's being given. But in reality, if we're going to get this pandemic under control, we've got to get into the pockets of high-level transmission. That includes minority populations, areas with lower socioeconomic status where there may not be internet access. It includes agricultural workers who are mobile and who may well have the opportunity to move the infection around as they move, but who really represent a high-risk population. Unless we get at these high-risk pockets, we are going to have a difficult time getting the overall pandemic under control.
Great, thank you. One question came up. Can you speak about the vaccine being developed at Emory University, which the person who submitted the question said heard is supposed to remain highly active even as the virus mutates?
Yeah. Again, I want to just stress that we can do neutralization tests by looking at sera of people who have been vaccinated, and then seeing how well it neutralizes these variants or other things like that, to get some idea. If it fails to neutralize, then it won't work. But what we're seeing is some possible reductions. So we just can't make those kinds of statements that yes, this vaccine will work against all these variants. But also, I'm not sure which vaccine the person's referring to. It's being developed at Emory. I would have to hear from what vaccine is that?
Right. But that was what the person had just put in there, was that they heard about a vaccine from Emory University.
Yeah, so, but what vaccine is that? I don't know what vaccines are at Emory University. So.
Well, question here is, if vaccinated people may still be able to infect other people, is it possible to achieve herd immunity through vaccination?
Well, and again, we'll have to find out, but vaccines could reduce the transmissibility of infected people by lowering viral load and other mechanisms. So sure, we may be able to achieve herd immunity, with high levels of coverage with vaccines like these. But so it's possible, yes, but I don't think we're going to rely on that. Herd immunity is a pie in the sky concept, especially for a virus as transmissible as the one we're talking about. And it's not really a state. You either have or you don't have herd immunity. What you have is reduced levels of transmission as you get more and more people vaccinated, and get that reproductive number below 1. And then the virus could eventually go to very low levels, probably not go away. So I think, yeah, it's possible, but we just don't know enough yet about these vaccines. Yeah.
All right, I think I'm going to ask you this question because you just got the vaccine, as you just said. There's a couple of questions here related to preparation before the vaccine and then the actual administration of the vaccine. So the questions are, do you recommend taking Advil or Tylenol prior to getting the vaccine? And I've heard that you shouldn't get the two vaccines in the same arm. Is there anything to this? So, so you're the expert because you just got it in the arm there, right?
Yeah, I mean, Glenn may have to help with this too, because he's more biological than I am. But I don't think it helps to take ibuprofen or Tylenol or Advil or one of these drugs before you're vaccinated. Because for one thing, you may have no reaction at all. And some people are like that. So I think it would make sense. I've been involved in vaccine campaigns where, like the VSV vaccine for Ebola, where we did give people these, ibuprofen before they were vaccinated, because we wanted to try to, in a ring situation, we didn't want the vaccine reaction to mass natural infection. If somebody was naturally infected, we wanted to know. But yeah, I don't think one would take anything before they got vaccinated. And I don't understand the 2-arm question. Does it mean the same arm 3 weeks apart or a month apart?
I think that's what the
yeah. I don't think it makes any difference which arm you get vaccinated in.
The arm shouldn't make any difference. I do think that again, we don't recommend that people routinely take prophylaxis in advance, just simply because you may not need it. And why take medication you don't need? But be aware that you might need it. And if you do, definitely at that point in time, take it.
Mm-hmm.
Okay. I think we're going to end with this 2 sets of questions here. And if we didn't get to your question, we will try to answer those off of the webinar. But these are related to holding events. And the one is that they hold an event for middle school and high school students with exhibitors. We're scheduled to host the event in April, but are considering moving it to the fall. What precautions should I take in terms of protocols for this event? And then a similar question was, how much time do you recommend in classrooms or meeting rooms between them? Because they said thinking of the lingering droplets in the room. So they're both fairly related about precautions for the protocols for the event and then the idea of lingering droplets in the room. So.
Yeah, definitely move it to the fall. I will be guardedly optimistic, and you've seen iris curves. I think by April, hopefully our numbers are going to be down substantially. But you really don't want to take any chances, and we do want to try to minimize possible transmission. It's not something you want to get, even if you're a kid. In terms of the time between meetings and classes, there's not a magic number there. What's critical is what we call the number of air exchanges per hour. CDC recommends that you try to maintain 6 air exchanges per hour in a room to minimize the risk of aerosols. So basically, that's something that your friendly neighborhood air conditioner guy can probably calculate for you and tell you what the number of air exchanges per hour you have. I will tell you, many offices and classrooms here at UF are only 2 air exchanges per hour. And so what you're really looking for is, if you're in a room with 2 air exchanges per hour, then it means you're probably going to need to wait 30 minutes to an hour to get all the bad air out and good air in. In contrast, if you're in a room with 6 air exchanges per hour, then you know, a 10 to 15 minute break should take care of things. I mean, again, there's not a given number. It's really more a reflection of how well your HVAC system is working and how rapidly the air within the room is exchanged.
Thank you so much for that. Before we leave, are there any other comments that either of you would like to share before I close this out? I think we've got a lot of good information today. Okay.
I'm good.
Okay, great. Great. Well, thank you both so much. For those of you attending, as a reminder, we will send out today's recording of the webinar to all the registrants, in addition to posting it on the Ag Safety Center website. Remember to visit SCCAHS.org to register for upcoming webinars. In fact, our next webinar is coming up on February the 17th at 1 o'clock with Krista Court from U.S. Department of Food and Resource Economics discussing impacts of COVID-19 on Florida agriculture and marine industries. The UF-IFAS Pi Center just launched over the weekend a brand new podcast called Science by the Slice. And our first 3-episode series is on COVID-19. And as you can see there, one of our podcast guests was Dr. Morris. I think you'll really enjoy the podcast, and there's a lot of great information in these 3 episodes. So be sure to subscribe to Science by the Slice wherever you get your podcasts. Then after today, we'll also email a survey with a link to the recording, and we would appreciate your time in taking the survey and telling us what you thought about today's session. The survey should take no more than 3 to 5 minutes to complete. I want to thank our speakers, Dr. Glenn Morris and Dr. Ira Longini, one more time, as well as all of our participants for joining us today. Have a great day and goodbye.